Alterations in oxygenation, lower respiratory disorders. Acute bronchitis is inflammation of the mucous membranes in the bronchioles. It can be caused by Haemophilus influenzae, Streptococcus pneumoniae, and Mycoplasma pneumoniae, in addition to fungal infections such as Aspergillus. These clients experience fever, chills, malaise, headache, a dry, irritating, and non-productive cough, mucopurulent sputum. We encourage bed rest, antipyretics, expectorants, antitussives, increased fluids, and antibiotics. Nurses, be sure to monitor lung sounds, vital signs, and encourage coughing and deep breathing. Pneumonia is an inflammatory process that affects the bronchioles and alveoli. We do have different classifications or categories of pneumonia. This includes radiation, chemical, and aspiration. Bronchopneumonia may also be the lobar pneumonia, and the community-acquired or hospital-acquired pneumonia, so one of those two. These clients experience fever, chills, a productive cough, discomfort in the chest wall, malaise, and rust-colored sputum. We treat it with antibiotic therapy, hydration, oxygen, bed rest, chest physiotherapy, postural drainage, bronchodilators, analgesics, antipyretics, and cough expectorants or suppressants. So let's talk about some of the antibiotics. It may include penicillin. This has an adverse effect of urticaria, pruritus or angioedema, eosinophilia, and Stevens-Johnson syndrome. It includes like nafcillin, amoxicillin, ampicillin, penicillin G and V, etc. Your cephalosporins is a broad spectrum bactericidal, and there's 5 generations of cephalosporins so far. Contraindicated in anyone that is allergic to penicillin because they can actually react with a hypersensitivity reaction if you give them a cephalosporin. Adverse effects include mild diarrhea, abdominal cramps, rash, pruritus, redness, and edema. Several different drugs. First generation would be like your cefazolin or cephalexin. Second generation is your cefoxitin. Third generation, ceftriaxone or ceftazidime. Fourth generation would be your cefepime. And fifth generation would be your ceftaroline. Your tetracyclines can inhibit growth of a lot of your gram-negative and gram-positive organisms, along with some protozoans. It's also frequently recommended for acne. It is contraindicated in pregnant women, lactating women, or children under the age of 8. It does have side effects of discoloration of permanent teeth or hypoplasia of tooth enamel. It does retard fetal skeletal development, so very important to not give during pregnancy. Causes photosensitivity, which is that sensitivity to light, and can exacerbate lupus. These drugs include like doxycycline. It does interact with dairy products, so very important to not eat or ingest dairy products while taking this product. And it also interacts with oral contraceptives, so very important to know that. Your macrolides will be indicated when we have bacteriostatic, or it's a bacteriostatic and bactericidal. It's indicated for moderate upper and lower respiratory tract infections. Um, Adverse effects include your GI effects such as nausea, vomiting, palpitations. Can also include headache, rash, urticaria, tinnitus, and hearing loss. Examples of this would be like your erythromycin or azithromycin. Then we have our fluoroquinolones, which are broad-spectrum antibiotics for organisms that are difficult to treat. It can cause corneal staining and precipitates, causes taste disorders and nausea. Ciprofloxacin is in this category. Your monobactams are used for your aerobic gram-negative bacteria. So some of your moderately severe systemic infections. It can cause rash, nausea, vomiting, and diarrhea. By the way, when you're learning these medications, it's important to understand that a lot of them are going to have some of the same actions used to treat some of the same things. They're going to have some of the same side effects. Learn the main overall issues with the category, and then learn the differences. We also talk about expectorants and mucolytics, which aid in the expectoration of your excessive mucus or productive cough. They can also suppress a cough. They cause nausea, vomiting, or gastric irritation. The main mucolytic or expectorant is guaifenesin. One thing that we need to be aware of, excuse me, if we are administering this and it is suppressing the cough, we want people to cough things up that may be down in their lungs. So we may not want to over suppress. So we also need to look at our pneumonia vaccine, our pneumococcal vaccine. It's recommended in smokers that are 19 to 64 years of age, and it's recommended in clients that are 65 years and older. So there's different types of vaccines. One of them is called a polyvalent, and this is used primarily in adults. And then, we have the 13-valent, which is routinely recommended for children. The recommended vaccine schedule for those that are 65 years and older, they get 2 vaccines, such as the PPSV23, and then a year later they get the PCV13, or vice versa. For those that are 64 years or younger, or they have certain immune disorders, or they're smokers, they will get 1 to 3 vaccines. They'll have a vaccine 1 year apart, and if it's the same vaccine, we may go up to 5 years apart. So those clients that do have pneumonia, for nurses, it's very important to perform that respiratory assessment, including your lung sounds, your pulse oximetry, ABGs if they're necessary, cough and sputum assessments, and position the client in a semi-Fowler's position. So again, pleurisy is a symptom of issues such as pneumonia. It's not specifically a part of your core curriculum, but because it is involved with pneumonia, we're going to talk about it briefly. This is inflammation of the parietal and visceral pleura. So basically, the lining of the lung and the thoracic cavity. Excuse me. So the clients often have shallow respirations, and with every respiration, they have excruciating pain. They may also have a dry cough and fatigues easily, in addition to dyspnea. And when we auscultate their lungs, then we hear that friction rub. So it's irritated in between. We don't have that normal lubricant in between, so it's rubbing every time they breathe. We treat it with analgesics and antipyretics. The analgesics are frequently going to be NSAIDs. Nurses need to administer those medications. May require heat and cold, teaching the client to splint the chest when they're breathing or coughing, provide emotional support. But we need to encourage them to do their deep breathing exercises to make sure that fluids are not, that they're moving around, that they're not sitting in one place, and or developing atelectasis. Pleural effusion is an abnormal collection of fluid between the visceral and parietal pleura. It can be caused by things like tuberculosis, lung cancer, or cardiac issues. These clients may develop a fever, pain, dyspnea, and may also have a friction rub. We diagnose with a chest x-ray, a CT scan, and a thoracentesis is the treatment of choice. Thoracentesis is going to be a procedure in which a needle is inserted into the area where the fluid is collecting, and then we drain it off, either by pulling it off with a large syringe or attaching it to a tube that is then put in a negative pressure container, and it will actually pull the fluid out. We also treat it with antibiotics, analgesics, cardiotonic drugs, and maybe even a chest tube to continue to drain fluid. Nurses need to prep for the thoracentesis or a chest tube and monitor the drainage. To prep for a thoracentesis, these clients are going to be set up on the edge of the bed, leaning over a table. Often this procedure is facilitated by a portable ultrasound machine to help identify the area that needs to be drained. So this kind of indicates different positions for postural drainage. They indicates the lung areas that may need to be drained and the best position to put them in. Now, we can also add physiotherapy to that, where we provide some percussion or vibration to help loosen the secretions. Then we put them in a postural drainage position, and that helps facilitate the removal and or expectoration of these secretions. Influenza. This is not a stomach bug. This is actually an acute respiratory disease. We have major strains of A, B, and C subtypes. These clients have severe headache, muscle aches, anorexia, sore throat. They may have laryngitis, nasal discharge, and a dry cough. We want to do preventative, so encourage that annual flu vaccination. We may have to isolate in the hospital setting because this is highly contagious. So again, as nurses, we push that vaccine administration, especially in clients that are going to be very susceptible. It is, once again, an annual vaccine, and it's recommended in the older adult and children, especially those that are on long-term aspirin, and adults that have underlying health problems. Recommended in healthcare personnel. The newest CDC recommendations is all individuals over 6 months of age should be vaccinated with the flu vaccine annually. Another type of vaccine is the Haemophilus influenzae type B, or the Hib vaccine. It's recommended in clients that are predisposed to septicemia, pneumonia, cellulitis, arthritis, osteomyelitis, pericarditis, sickle cell anemia, immunodeficiency, and Hodgkin's disease. These Hib infections can lead to bacterial meningitis with 5 to 10% mortality rate and 20 to 40% with serious neurologic deficits. Tuberculosis is a bacterial infectious disease caused by the Mycobacterium tuberculosis. Its onset is insidious. These clients experience fatigue, anorexia, weight loss. They may have a slight non-productive cough, but later on they have night sweats, a cough that's productive of mucopurulent or blood-streaked sputum. They may complain of weakness, wasting, and hemoptysis, and dyspnea. We diagnose with the Mantoux tuberculin skin test, a chest x-ray, CT scan, or an MRI. Excuse me. And we treat it with drug therapy. Excuse me, once again. So we use the antimycobacterial, also known as an antitubercular medication. It is indicated in TB infections, contraindicated with major liver and renal dysfunction, optic neuritis, or chronic alcohol use. It does cause pyridoxine deficiency and liver toxicity. It interacts with a lot of drugs and can cause some false positive urine glucose tests. So interventions. When we're doing the Mantoux skin test, we use the purified protein derivative, also known as the PPD. We inject 0.1 mLs intradermally to test for tuberculosis. There is also the BCG, the bacilloclimate-guerin, which is a vaccine injection. It's not usually administered in the United States, but it will cause a false positive TB skin test. Now, if a TB skin test turns positive, we need to obtain a chest x-ray. If that chest x-ray shows signs of TB, then we need to obtain a sputum culture. Examples of some of these medications include your INH or your PZA, and there's several others. The issue with TB is it requires treatment that can last for months. People can be very non-compliant. So very important that we teach medication compliance. In addition to, non-compliance has led to some resistant forms of TB. This is something that you need to be familiar with. It gives you some guidance on how to read your TB skin test. We're looking not necessarily for redness so much, although we do look for that. We're looking for induration. So you never read a TB skin test just by looking at it. You have to get your hands on it and you have to feel it. It is done within 48 to 72 hours after the skin test. If it's over 72 hours, you have to redo it. Question. A 17-year-old client's mother has recently been diagnosed with pulmonary tuberculosis. The nurse would expect the healthcare provider to order which of the following tests initially? The initial test is that Mantoux test. Atelectasis is a collapse of the alveoli caused by aspiration, a mucus plug, fluid or air tumors, an enlarged heart, an aneurysm, or prolonged bed rest, in other words, immobility. These clients may have cyanosis, a low-grade fever, pain, dyspnea, increased pulse and respiratory rates, and increased secretions. We diagnose with chest x-ray, ABGs, and pulse oximetry results. We have to improve their ventilation, may require suctioning, deep breathing exercises, coughing, which helps expand that alveoli, bronchodilators, humidification, and oxygen. Chronic bronchitis is the hypersecretion of mucus or recurrent or chronic respiratory infections. Chronic bronchitis really is diagnosed as that chronic cough lasting for over a couple of months in 2 consecutive years. It can be caused by bronchial asthma, influenza or pneumonia, air pollution, and smoking. These clients experience early on a chronic cough that's productive of a thick white mucus and bronchospasms. We want to prevent recurrent irritation and we want to remove secretions. We encourage smoking cessation. We may give bronchodilators, increase the fluids, because again, we want to keep those secretions moist so they can bring them up. Postural drainage and steroid therapy. We also want to do preventative. So we're going to talk about education, eliminating those environmental irritants, your metered dose inhalers, and rest. Now I want you to look at the COPD client. He's in the typical tripod position where he's leaning forward, creating a tripod with his upper body and his arms. He's also doing the pursed lip breathing. Emphysema is another one of our chronic obstructive pulmonary diseases. It involves a hypersecretion of mucus and recurrent or chronic respiratory tract infections. It can be caused by bronchial asthma, influenza, or pneumonia, air pollutants. It's frequently involved with an increased retention of carbon dioxide. So these clients begin to develop that barrel chest because they are unable to get rid of all of the air that's in their lungs due to obstructive secretions. And this usually happens in the terminal bronchioles. They don't have a lot of cyanosis. They may actually be fairly pink. They're the ones that you're going to see doing that pursed-lipped breathing a lot because they're trying to get rid of more of that carbon dioxide. They are dyspneic. They have difficulty breathing if you lay them down flat, and definitely have exertional dyspnea. Clients that have COPD, we need to make sure that we're providing appropriate rest periods. They may not be able to talk to us in full sentences. They have to take a breath between every few words in order to communicate. They may be on continuous oxygen, but it's going to be low doses of oxygen. because what happens when we have COPD, our normal trigger to breathe is going to be high levels of carbon dioxide. So when we have high levels of carbon dioxide, it tells us that we need to breathe. We have low levels of oxygen. So we need to be breathing, okay? With our COPD clients, their trigger to breathe, because they're hanging on to all of this carbon dioxide, that is no longer a trigger to make them breathe. So now their trigger to breathe is going to be low levels of oxygen. If we start giving them too much oxygen, then we can knock out their trigger to breathe and they can just stop breathing. So we never give oxygen over 4 liters. Average is going to usually be right around 2 liters. We can give it at a higher rate for a short period of time, but we need to be backing that rate down as quickly as possible. These clients also frequently use their accessory muscles to breathe. Asthma is inflammation and bronchoconstriction of the airway, usually brought on by hypersensitivity of the airway. So we may see allergic or non-allergic asthma. We diagnose by chest auscultation and pulmonary function studies. These clients experience shortness of breath, wheezing, coughing, production of thick sputum with prolonged expiration. Again, they have some obstruction there. They're trying to get the air out of their lungs. We want to teach them to avoid any allergens or triggers that may initiate or cause an asthma attack, administer antihistamines, and we may do desensitization, which is giving allergy shots, where we put a diluted allergen in an injection and give that usually on a weekly basis. And then we slowly increase the strength of the allergen in the shot, hopefully to desensitize the client. They no longer react to that particular trigger. So medical management, once again, includes some pharmacological issues. Inhaler administration. If we use those metered dose inhalers, all children should use a spacer. That spacer also assists clients that are unable to correctly use inhalers to inhale the medication. And it might better disperse the medication for better inhalation. When they're using the inhalers, they have to exhale all the air in their lungs, squeeze it at the same time they're inhaling, and they want to get that medication all the way down to their lungs. So, some people just are not able to do that, and they just recommend that kids should always use the spacer because you squirt the medication into the spacer and then they just inhale it when they're ready. So some of the medications that we may use would be like your mast cell stabilizers that can prevent or control certain allergic disorders by blocking mast cell degranulation. It also stabilizes the cell and prevents the release of histamine and related modulators. We have our beta-2 adrenergic agonists, which are considered to be your bronchodilators. Those are indicated with acute asthmatic attack or episode. So it's going to be like your rescue inhaler. It can also be used in the prevention or relief of bronchospasm or bronchoconstriction. Should not be used with uncontrolled hypertension, cardiac dysrhythmias, or clients that are at a high risk for stroke. Adverse effects include insomnia, restlessness, cardiac stimulation, hypertension or hypotension, headache, and one of the most common complaints is a tremor. It can also cause anginal pain. We encourage clients that take both a bronchodilator and a maintenance drug, such as a steroid. You take the bronchodilator first because the bronchodilator is going to help open up all of the airways so the maintenance drug can then reach all areas of the lung. Examples of your bronchodilators include like your albuterol or your fluticasone. Then we talk about our methylxanthines. These dilate the airways with asthma or COPD. Contraindicated if we have uncontrolled cardiac dysrhythmias, seizure disorders, hyperthyroidism, and peptic ulcers. They can cause nausea, vomiting, anorexia, tachycardia, palpitations, hyperglycemia, and increased urination. Examples of this medication would be like theophylline, aminophylline, and caffeine. Next medication is anticholinergic. This is inhaled because we're talking about asthma. It will help prevent bronchospasms. So this is going to be more of a maintenance drug. It prevents bronchospasm because of its slow and prolonged action. It is used cautiously in clients that have acute narrow angle glaucoma and prostate enlargement. It can cause dry mouth and thirst, nasal congestion, heart palpitations, GI distress, urinary retention, and increased intraocular pressure, headache, coughing, and anxiety. Ipratropium is one of the main medications that we use with the anticholinergics. One thing to remember about this is it dries things out. Your leukotriene modifiers are a prophylactic long treatment and prevention medication. It can also be used with allergic rhinitis. It should be taken even if there are no symptoms. Contraindicated if we have allergies to povidone, lactose. Adverse effects include headache, nausea, dizziness, and diarrhea. Examples include montelukast as one of those medications. Again, this is a maintenance drug. It's not to be used to help treat an acute episode. Those rescue inhalers are for that. So we need to teach our clients about medication administration, maybe oxygen administration. We need to teach them how to use their metered dose inhalers. We also need to teach them how to do peak flow monitoring. Peak flow monitoring is where they daily monitor what their lung volume status is. And it is going to guide their treatment for the day. So if they are a green, everything is good. They don't need to do anything different. If it's a yellow, they may need to do additional medications or decrease their physical activity, etc. If it's red, that requires immediate treatment. So basically, the peak flow meter is going to guide their treatment for that day. Question: The nurse is instructing the client with asthma about the importance of measuring the peak flow rates. Which of the following statements about the purpose of measuring peak flow rates is correct? It's going to be B. It measures his response to his therapy. How well is he doing? Pulmonary embolism is the obstruction of pulmonary arteries or branches of arteries from a blood clot. These clients have an immediate onset of pain. They may have tachycardia, dyspnea, fever, cough, blood-streaked sputum, cyanosis, an irregular heart rate, and wheezing, which, by the way, is one of the very typical symptoms that you see with asthma patients. They have wheezing. These clients will be given IV heparin or an IV thrombolytic drug. If the clot is significant enough, they may require an embolectomy. We need to teach about the prevention of DVTs. If they have a DVT, that DVT can break off and lead to a pulmonary embolism. And pulmonary emboli can be fatal. Lung cancer comes from a prolonged exposure to carcinogens, especially cigarette smoking. And you don't have to be the smoker. You may just be inhaling secondary smoke. These clients have a cough that produces mucopurulent or blood-streaked sputum, anorexia, weight loss, dyspnea, or chest pain. We diagnose with a chest x-ray, CT scan, PET scan, MRI, or even a bronchoscopy. Unfortunately, lung cancers are asymptomatic in the early stages, and they can be pretty well established and even metastasized before they start showing significant symptoms or before it's discovered. Surgical management may require a lobectomy or even a pneumonectomy. Lobectomy removes just a lobe or multiple lobes. Pneumonectomy removes the entire lung, followed by chemotherapy or radiation. These clients require emotional support and postoperative care. They frequently will come out of surgery with a chest tube, and we'll talk about chest tubes more in depth during class. So trauma, fractured ribs, usually a result of some kind of a trauma or accident. We may also see a flail chest, and with the flail chest, you kind of see that picture here in your slide where we have multiple breaks in the ribs, and basically they become completely separated from the rib cage. They are going to have what we call paradoxical movement. So when you breathe in, normally our chest expands, but with that flail chest, that flail portion is going to go in instead of expanding out. And when we expire, where our chest usually goes back in, that flail part is going to go out. So again, look at your picture and hopefully that will help give you a good visualization. Clients that have fractured ribs have severe pain on inspiration and expiration. So you can imagine that one of the major complications is going to be respiratory infection or respiratory acidosis. They don't want to breathe because it hurts. So they're breathing very shallowly, or they're breathing very quickly, and they're increasing the amount of CO2 that's in their lungs. Your book tells you that we can use a rib belt or an elastic bandage, but these can influence the ability of the client to take a deep breath, so they may also be contraindicated. Definitely analgesics. We also need to teach splinting to encourage them to do their deep breathing and coughing. Good pain management is so important. And then our penetrating wounds. These can cause a pneumothorax, which is a collapsed lung. A hemothorax, which is a collapsed lung due to blood filling that lung space instead of air. Subcutaneous emphysema, which is air that comes from a collapsed lung that gets into the tissue. So it's then like bubble wrap. You touch the skin and you start feeling the popping that you feel with when you're popping bubble wrap. We may also see hemorrhage or a lung contusion, damage to the surrounding tissues, and fractured ribs from those penetrating wounds. We treat it with airway management and emergency treatment. Most clients that have a pneumothorax or a hemothorax will require a chest tube and definitely oxygen. These clients are also going to have an asymmetrical chest wall movement because one lung is no longer inflating because it's collapsed. And thoracic surgery. Thoracic surgery, where we get into the thorax, is called a thoracotomy. We're opening up the thorax. We do this to remove fluid, blood, or air, tumors, to remove a lung, or to repair structures or trauma, or do a biopsy. Preoperatively, make sure we get that good lung assessment and history. Postoperatively, we have to manage that chest tube. So question, the client's left thoracotomy tube is connected to a water seal, drainage and suction. This is a chest tube. The client is to be transported to the x-ray department, so how will the nurse transport the client? A, will disconnect the suction and maintain that water seal drainage system.